you're the same person. Okay. You go ahead with your next paper on autologous transplantation of neurosensory retina.
I don't have any financial disclosure regarding its talk. The main purpose of this study was anatomical and functional outcomes following a triple layer graft, so using a neurosensory graft as well as RP choroidal grafts in patients with advanced neovascular AMD which are associated with fibrosis and atrophy. This was a prospective study of 16 eyes conducted over a period of 5 years. None of the patients has received a multiple anti-VEGF injections in the past 1 year prior to the surgery. So the maximum dose of anti-VEGF was tried in most of these patients. All patients underwent part plana vitrectomy with triple layer, that is neurosensory, as well as RP choroidal grafts. The main indications were hemorrhage in 1 patient, and non-responders in 5 patients, fibrosis in 8 patients, and RP tear in 2 patients. This is a technique which we used. The transplantation assisted PVD induction was done. Then a subretinal injection of BSS was done in the temporal quadrant to induce a retinal detachment. Then a peripheral retinotomy was done to get access to the subretinal space. Once you're done and fold the retina and CNVM removal was done, there was not much use. The minimal gentle cautery diathermy was done to stop the bleeding. The temporal RVS site for the RP choroidal graft, approximately size of around 3 to 4 disc diameter was chosen. Using a bimanual technique, the graft was taken out and placed subfoveally under perfluorocarbon liquid. Since there was a fovea was atrophic, the iatrogenic macular hole was created and a retinal graft was taken to cover off that fovea macular hole which you have created. Once you have done, unfold the retina, now the main part is moving the neurosensory graft which you have taken onto the macular hole area which you have created. Move it gently towards the macular hole area and it placed over the RP choroidal graft. Then you can diathermy the neurosensory graft area and do a gentle laser to that area. Then a perfluorocarbon silicon oil exchange was done. The graft was placed subretinally in 12 patients and intraretinally in 4 patients. The size of the choroidal graft, as I told before, ranged from 3 to 4 disc diameters large. Retinal graft, approximately around 0.5 to 1 disc diameter larger than the macular hole. Silicon oil and tamponade was used in all the patients. The follow-up protocol included assessment of best corrected visual acuity, ophthalmoscopic examination, fundus photography, autofluorescence, and the OCT and OCTA, and the fixation testing was done using a microperimetry. The mean age was around 71 years. The mean follow-up was around 6 plus or minus 3.4 months. The preoperative fixation was based on the reading was absent in all the patients since it was an advanced disease. The mean best corrected visual acuity improved from counting fingers to 20/800, which was statistically significant. Vision was stable in 12 eyes and improved in 4 eyes. Reading ability improved in around 7 eyes. Reading acuity improved from 3 to 6 months. So over a long-term follow-up, there was a much better improvement in the reading acuity. Limited subretinal hemorrhage was seen in 2 eyes intraoperatively. Post-op graft atrophy was seen in 4 patients, epiretinal membrane development in 3 patients, and dislocation of graft in 2 patients. None of the eyes developed the PVR or RD. The OCT findings, you can see here clear cut. There is a yellow demarcation line which is seen between the original neurosensory retina and the graft. In the intraretinal group, the graft is very well made out and it is the edges of the graft and it very well integrates into the surrounding retina. The edges of the free graft can be very well made out and even the intraretinal fluid is disappeared in most of the patients, and even the outer retinal restoration was seen in around 14 eyes out of the 18 eyes. What does the FFA and ICG showed? The revascularization of the choroidal graft was seen. On a dynamic ICG, there was a feeder vessel which was seen at the contact of the graft with the underlying choroid, but on retina there was no signs of neovascularization. The choroidal graft clearly seen on the outer OCTA images. You can see the yellow arrow with this, but the superficial and deep retinal vasculature are preserved in the area of neurosensory retina. As we know that OCTA was limited by the segmentation and artifaction errors. The autofluorescence graft was homogeneous throughout the graft and it was maintained up to 6 months, but it started fading on a long-term follow-up. The microperimetry showed significant sensitivity along the margins of the retinal free graft as well as over the choroidal free graft. And increase in retinal sensitivity correlated with the improvement in best corrected visual acuity in most of the patients. Submacular surgical trials have shown that just excision of the transplantation of the RP and choroid is not good enough to improve the visual acuity. So one need to add the neurosensory retina as a triple layer to get a maximum outcome and a better visual functional outcome. So main concerns are, one is if there is an hemorrhage, there could be encapsulation of the graft. And other thing is, if you take an RPE from the periphery, whether the functionality of the RPE in the periphery correlates with the functionality of the macular RPE. Ectopic synaptogenesis, because we don't know how the neural connections work post-graft. The vascularization of the choroidal vessels which develops runs parallelly. But if you look at the normal choroidal vessels, they are radially arranged, not parallelly. So this is one more concern, whether this is abnormal vascularization or does they differ from the normal choroidal vasculature. So in conclusion, even though it's a complex procedure, should be considered in the end stage of AMD patients, but the patient selections, the graft perfusion, the amount of damage to the RP during insertions, and the condition of the overlying retina, especially the outer retina, determines the outcome. With this, I would like to conclude my paper. Thank you.
I think we are running behind time, so let's go with the next lecture.
Thank you.